Bismillah ar-Rahman ar-Rahim. I would like to thank the organizing committee of allowing me to come here among my friends and colleagues to present my experience in cataract and diabetic patients. I believe it will be almost the same like Dr. Muhammad Tawfiq has done, but in another perspective from the point of view of anterior segment surgeon. First of all, some statistics. Diabetes is nearly 1 in 8. This is a lot, and it is increasing. And cataract is the leading cause of blindness all over the world in 51% among all causes of blindness. Patients with diabetes have 5 times the risk of cataract development. And patients with diabetes develop the cataract 20 years earlier than their counterpart non-diabetic. And usually cataract surgery is required in the earlier age. And if you revise yourself and asking yourself what is the percentage of cataract in diabetics among my cases, it should be in the range of 20%. Personally, in my cases, it's much more than that. Maybe 30, maybe 40. This is because they develop cataract earlier and they mature more rapidly. Also, speaking about statistics, cataract is the most common procedure performed all over the world, and therefore we should prepare ourselves more and more for such frequently done procedure. And the visual results nowadays are very good. 612 is usual in over 95% of cases. These are the indications of cataract, like Dr. Muhammad Tawfiq has said just now. There are 2 indications to achieve a better visual acuity for my patient and also to allow better visualization. Sometimes we are doing the cataract earlier in order to better follow the diabetic retinopathy. If you have a patient which is with no diabetic macular edema, therefore he is like non-diabetic. You will operate as a routine. But if there is pre-existing diabetic macular edema, there is more risk of worsening of this diabetic edema after surgery, and you should do something for that. This has been with the Q protocol of DMCR study. Cataract, ideally try to stabilize the diabetic macular edema before cataract surgery. The main weapon, as we have seen and as we know, are the anti-VEGFs. Long-acting steroids, maybe in a small percentage of cases, and nowadays we are not anymore doing focal or grid laser photocoagulation that used to be done beforehand. These are the cases that you should treat before cataract surgery. And in the returning back to the history of cataract surgery, in the era of intracapsular cataract extraction, the risk of progression was huge, and I have seen that in my own PhD thesis since more than maybe 30 years ago. The progression was up to 55% of cases. In the era of extracapsular cataract extraction, the percentage is better, but still the progression of retinopathy is high. In the era of phacoemulsification, the progression should be low, but still it is at higher risk than the normal population. The role of anti-VEGF at the end of surgery. There is a study which is important that have compared patients that you inject as a routine. In this study they have done Avastin, but you can inject anything of the anti-VEGF at the end of surgery and compared to control, and they found that retinopathy progressed in about 45% of control versus 11% in the non-injected eye, meaning that the mere injection of Avastin at the end of your surgery will decrease the risk of progression of diabetic macular edema a lot. Cataract, the role of anti-VEGF is now the first line of therapy, as we have seen and as we know quite well, and this will give the best anatomical and visual results for our cases. Regarding the retinopathy, the overall grades of retinopathy, in the era of intracapsular, there was a definite progression, and this picture is dating more than 30 or 35 years, and this is from my own thesis, that after cataract surgery by 1 month or 1.5 months, the cases have progressed a lot to high risk proliferative retinopathy. Also, the early treatment diabetic retinopathy study report 25 analyzed the progression of retinopathy in cases of extracapsular, and I have found that there is a two-step worsening in the retinopathy after extracapsular cataract extraction. The picture after phacoemulsification is different a little bit. Ideally, if the media allows, try to stabilize the retinopathy before going to cataract surgery. And this is by properly done PRP, as Dr. Muhammad Tawfiq has emphasized. If the media do not allow, and this is somewhat rare nowadays, consider the use of anti-VEGF injection to revert the retinopathy prior to cataract surgery. It is the same like the protocol S that we are doing, injecting patient in order to control the retinopathy, doing the cataract, and then continuing the PRP after the cataract when the media allows, and ideally it's 2 to 3 weeks after the surgery. What is the timing of the cataract surgery or phacoemulsification for diabetics? It's early rather than late, before the media will hamper the view, and more rapid recovery and better visual results are in early cases. Hints about the surgery: you should use your usual efficient technique. Use monofocal or toric, but personally I don't like multifocals in such cases because of the instance of the macular edema. Avoid silicone IOLs, avoid AC IOLs in such cases in diabetic patients. Cataract should be one of the most successful interventions in the history of medicine, and the success rate in the straightforward cases is almost 98%. But in special cataract cases like the diabetics, it can be much less if you will not properly manage such cases. Difficulties during surgery: yes, due to the cornea and due to poor pupillary dilatation, and you should use all your weapons. Following cataract surgery, we have a much higher incidence of cystoid macular edema, the Irvine-Guise syndrome. This is well known that after cataract surgery, the incidence is much higher than 50% almost. And for that reason, you should differentiate the diabetic macular edema from pseudophakic macular edema. Diabetic patient, you can do it by OCT, and if not, you can do it by fluorescein, because the treatment is different in both entities. The differentiation is by fluorescein angiography. You will find the hot disc, the crystalloid pooling, and the OCT from up down. It is for those who are doing OCTs, they can easily differentiate between both cases because the management is different. This pseudophakic macular edema is almost in 50% of cases, and the role of topical non-steroidal anti-inflammatory is very important. Personally, I am giving them 3 times per day for almost 6 weeks after routine cases in diabetic patients. We use topical steroid and non-steroidal anti-inflammatory. Maybe the non-steroidal are more important than topical steroids here. Usually I'm doing the steroid in a tapering manner, but the non-steroidal I'm continuing it 3 times for 6 weeks. Regarding diabetic macular edema, we all know that the mainstay of management is the anti-VEGF or rarely steroid injection, intravitreal injections. This is the worst case scenario, that you have total cataract with rubeous, adherent, and vascular glaucoma. What you should do: stepped approach. Do ultrasound, like Dr. Tawfiq has said, and then use anti-VEGF. Try medical control of IOP all through the period of treatment. Possible cyclophotocoagulation, then phaco with precautions, and then PRP just 2 to 3 weeks after the phaco, and all through monitor the IOP all through, and just after the surgery control the diabetic condition by anti-VEGF or PRP. This is how we are managing according to diabetic retinopathy severity. If there is no retinopathy or mild non-peripheral diabetic retinopathy and no diabetic macular edema, it is standard phaco. If there is moderate severe non-peripheral diabetic retinopathy and no diabetic macular edema, standard phaco combined with non-steroidal anti-inflammatory to avoid cystoid macular edema. If you have mild or severe non-peripheral diabetic retinopathy with macular edema, here is the role of the anti-VEGF pre, during, and after phaco, and the role of non-steroidal to control the Irvine-Guise syndrome. And if you have peripheral diabetic retinopathy plus or minus diabetic macular edema, use anti-VEGF, use PRP, maybe pulse planar vitrectomy, combined with the phaco, if indicated, with all the procedure done during this posterior segment surgery. And I agree with Dr. Tawfiq, let the posterior segment do it instead of you, because he is controlling the situation much better than the anterior segment surgeon. And I thank you very much.